Good morning and welcome to the session on using continuous quality improvement to strengthen implementation fidelity. I'm Dr. Colleen Killian from James Bell Associates. I know people are kind of sitting at their tables that have their names on them, but please feel free to move in if you would like to, because at the end we'll be having the ability to ask questions and discussion, and it might be really kind on the people that have the microphones not to have to run to the far ends. So if you don't mind, that would be great. Okay, so today to delve into this important and challenging topic, we've actually invited 3 individuals who have some really valuable experience in this area. And we'll be talking more about them later, but we have Dr. Marlo Perry, who's the evaluator from Pennsylvania, Tina Willauer, the director for START Kentucky, and Lynn Posey, the assistant director of Behavioral Health Kentucky. And Ruth Huebner and I will be facilitating the session and handling discussion questions later as you have them. The overarching goal today is to improve knowledge regarding the continuous quality improvement process and fidelity, and specifically to present information on the development of fidelity measures, the collaboration with program staff, which is a vital component in the process, how fidelity informs the CQI process itself, and using fidelity data to improve adherence to and alignment with program impacts and program outcomes. Today's presentation will begin with a brief introduction and overview of fidelity implementation, followed by a presentation by Dr. Perry on her valuable experience in Pennsylvania. Following her presentation, Ruth will provide a brief introduction of CQI and introduce our presenters from Kentucky. The overarching goals of every Title IV waiver demonstration is to improve the safety, permanency, and well-being of children who come into contact with the child welfare system. Fidelity is an important component of achieving these goals. The Title IV waiver demonstrations are utilizing evidence-based programs to effect change. These EBPs have research supporting their effectiveness, and fidelity to those models is important to achieve the likelihood of achieving those goals. In addition, it provides important information to the CQI process itself. Implementation fidelity is the degree to which interventions are delivered as stated and measured by the extent of adherence to the essential program strategies. So that's our classical definition there. Achieving fidelity in complex systems, such as the child welfare, often requires mitigating adaptive challenges. Fidelity can enhance the process. In order to elucidate the topic of implementation fidelity, we've invited Dr. Marlo Perry to present today. Dr. Perry is a research assistant professor with the Child Welfare Education and Research Programs in the University of Pittsburgh School of Social Work. She holds a master's in education and psychological services and a PhD in school and community and clinical child psychology from the University of Pennsylvania, and has more than 15 years of applied research experience in early child education, health, and child welfare. Dr. Perry is co-PI for the evaluation of Pennsylvania's Child Welfare Demonstration Project. Her other projects include the evaluation of Pennsylvania's core caseworker and supervisor training, ongoing evaluation of transfer of learning, and an annual 4E program evaluation. So without further delay, I'll hand it over to Dr. Perry.
Good morning. Just out of curiosity, how many folks here are on the evaluation side of things? Okay, and then program side of things? Okay, a good mix, great. So hopefully there will be something for all of you here. So today I'm going to talk about assessing fidelity of family engagement in Pennsylvania's Child Welfare Demonstration Project. And so to start, I'm just going to give a brief overview of Pennsylvania's project, and then I framed the discussion today in terms of 3 challenges that we have come across in our first couple of years. The first, how do we assess fidelity across different models of family engagement? How do we collect data without overburdening our system partners? And then how do we use that information as part of a CQI process? So Pennsylvania is a state-supervised, county-administered state. We have 67 counties. The ones in green are the ones participating in the demonstration project. So 5 of the 6 counties came on in the first year, so they comprise cohort 1. The first year was fiscal year 13. And then Crawford County up in the, this isn't going to point all the way over there, in the upper left comprises cohort 2, and they entered the project in fiscal year 14. So as you can see, the participating counties are scattered across the state, but we also have good representation in terms of urban, suburban, and rural. You can see that Philadelphia is participating, as well as Allegheny County, which is home to Pittsburgh, so sort of the urban centers of Pennsylvania. Dauphin, sort of in the middle of the state, is home to Harrisburg, which is our state capital. And Lackawanna is home to Scranton, home of The Office, if there were any fans of that. And so those have sort of an urban, suburban, rural mix. And then up in the left are Crawford and Venango, which are primarily rural counties. Pennsylvania's project has 3 primary components, and they were implemented in sort of 2 phases. So in their first year in the project, counties either scaled up or began implementation of comprehensive assessment tools. So in order to consistently assess strengths and needs of youth and families in their counties. And they're using the CANS, which you'll hear, a lot of you are familiar with, I think, and you can hear more about. I think there's a session tomorrow. So that's the Child and Adolescent Needs and Strengths tool. And then the FAST, or the Family Advocacy and Support tool. And then for little ones, birth to age 5, using the ASQ and the ASQ SE. The second component is family engagement. And there are a few different models there, and I'll talk more about those in a little bit. So that was comprising the first year, is scaling those up or starting to implement comprehensive assessment tools and family engagement. And then in year 2, counties selected which evidence-based practices they were going to implement. PCIT, or parent-child interaction therapy, is actually being used in all participating counties. So we're focusing a lot of our evaluation on that particular EBP. And Triple-P, or the Positive Parenting Program, was selected by a few of them. So we're focusing on that as well. But counties were free to select whichever EBPs they wanted to. So one is using MST or DBT. I think one is using trauma-focused CBT, Safe Care, Home Builders, things like that. We're also collecting some basic dosage information on those, but focusing primarily on PCIT and Triple-P. And today, like I said, I'm here to talk primarily about the family engagement piece. Just very briefly, I'm not sure why that first box is so big, but I'm going to talk through the state's theory of change. And I'm not going to read every last word here, but essentially, if families are engaged as part of a team, and if they receive comprehensive structured assessment to identify needs and strengths, and that information is used to develop a plan, and then if that plan then connects them to evidence-based services to address those needs, then we can expect better outcomes. Youth and families are more likely to remain engaged in and benefit from treatment so that they can remain safely in homes, experience fewer placement changes, experience less trauma, and experience improved functioning. So that's how those 3 components, how we theorize those 3 components all work together. So as you saw on the previous slide, there are several family engagement strategies that counties are utilizing. Family group decision-making, or FGDM, family team conferencing, conferencing and teaming, and family group conferencing. So lots of meetings and conferences and teamings. And they're all similar and yet slightly different. FGDM, some of you may be familiar with that, and so a pivotal component of that is that private family time. So some of these models have private family time, some do not. Some cast the net very widely in terms of bringing in extended kin and support systems, and some cast that net a little bit more narrowly. So in addition to having the models be slightly different from each other, there are also quite a few differences in terms of implementation across the counties. Some counties are simply scaling up an existing intervention, so may have already been using FGDM with a small population and are now offering that to all families. Other counties adopted a brand new engagement model. And so that comes with it, a lot of education and training, things that go along with that. Some counties have contracted providers who facilitate the meetings. Some have designated CYF staff who facilitate the meetings. And one actually has their caseworkers facilitate those meetings. The goals of the meetings vary from model to model across and sometimes within counties. And actually, counties may be using more than one of these models as well. Target populations are slightly different. And the timing of meetings varies from county to county in terms of when that initial meeting has to happen. Is that within 30 days, within 45 days, and then how frequently follow-up meetings happen? Some are 60, some are 90. So lots of variability. I'm sure that's every evaluator's dream, is to have so much variability. So that led us to challenge number 1, which was how do we assess fidelity across these different models of family engagement? And we worked with some folks at HSRI. I don't know if there's anybody from HSRI here today or not. In consultation and collaboration with them, they helped us whittle down. We read through all of the county IDIRs as well as some background literature on some of these models to whittle it down to 5 core components that were consistent throughout these different models. The first is that conferences are facilitated by neutral and trained staff. So regardless of who facilitates and their familiarity with the family, they should still have a certain level of training, and they should still be neutral and fair in their facilitation. So no hidden agenda, no apparent biases. Second is related to partnerships. So effective partnerships are promoted among the Child Welfare Agency and private and community services. And this partnership extends to the family as well. So this should be a collaborative process between child welfare and service providers and the family. And they should work together as a team to help the family reach their goals. Third relates to outreach. So there should be outreach to kin or other supportive folks as potential caregivers or supports to the birth parent. As I said, some models cast that net very widely and some not as wide, but there's, across all of those models, there's still some outreach to other folks. Fourth, families and supports are prepared for the conference or for the meeting. Everyone attending the meeting, providers as well, but this tends to be a new experience for a lot of families. So they should know what to expect. They should know what's expected of them. They should understand the purpose of the meeting. So they should be prepared for that before it happens. And then fifth, families are helped to identify and access appropriate and meaningful services. Ideally, with some of those resources are going to be at the meeting with you, and so hopefully personal connections can be made. Ideally, you don't just want to hand mom a business card and say, go call this resource. You want to help them actually make meaningful connections with those resources. So these were, again, common to all of the models. So then how do we assess fidelity to those 5 core components? On a broader level, at a worker and a county level, we're doing a few different things. We are observing a handful of meetings in each county each year. Obviously, this is not a high volume, because as you saw, they're scattered throughout the state, and our team is pretty fantastic, but they can't be everywhere all at once. But so far, this has been enough to sort of give us a feel for the tone of how those meetings go. We have a structured observation tool, and several of us go out at one time. So we're doing some observations. We have an annual facilitator survey that we send out to everybody that facilitates meetings, and that gets at not only their initial training that they received, but also ongoing training and coaching. And then focus groups and key informant interviews, and we are doing those and have done those with caseworkers and supervisors, as well as youth and family members, to get a better understanding of what their experience has been with these engagement models. But we also want to be able to collect fidelity information at a case level. And so we developed a series of tools as well as a survey. So these first 3, the facilitator face sheet, the baseline form, and the follow-up form. These are all tools that the facilitator completes, either just before or just after a meeting. And they collect demographic information, asks about the purpose of the meeting, who attended the meeting, where the child was living at the time of the meeting, and if any changes in the child's living situation happened as a result of that meeting, as well as services and supports that the family is receiving. So these are primarily focused sort of on the what of the meeting. And then the family conference survey is getting more at the how. And so this one, the facilitator does not complete, but everybody else who attends the conference completes. Youth, if the youth is old enough, family members, providers, everybody is asked to complete this survey. And this is getting more at those 5 core components. So just going to talk very briefly about the history of this. This was adapted slightly from a survey that was created for a statewide evaluation of FGDM. And this is based on Joan Pennell's work. I'm not sure if folks are familiar with her work around family engagement. It's a 4-point Likert scale, and all the items are worded positively in the same direction. And the group here is the object of the rating. Originally, the original tool was more of a satisfaction survey, but through several iterations, it's become more of a fidelity survey. And this original survey was developed in partnership with county and state stakeholders, including some participants from counties who would later be in the demonstration project. So some folks were already familiar with this tool. And after 1 year of implementation, we also incorporated some partner feedback and issued a slightly revised tool. So I'm not going to read through each of these items, and those are actually very hard to read on the screen, but items are things like the facilitator was fair, the conference was a safe place to discuss feelings and opinions, the plan included ways that the family will help out, things like that. So now that we figured out what information we wanted to collect, we needed to figure out how do we collect it. So how do we collect it without overburdening our system partners who are already doing quite a bit? As I said, family engagement was just one piece of the demonstration project. And family engagement data was not and is still not included in any of the county data systems. Pennsylvania does not have a statewide system. We don't have a SACWIS, so we are already dealing with across the 6 counties, we're dealing with 4 different county data systems. 2 of the counties have actually changed data systems in the past 2 years, adding to that complication. But family engagement data is not included in those. Counties have been sort of trying to get up and running, incorporating the assessment information into those, and family engagement data just hasn't risen to the top in terms of priorities. We've talked about how to use technology. Can the facilitator tools, can they be completed on a laptop and uploaded somehow? Can we do the family conference survey via smartphone? But those obviously have their own limitations. Not all of the places where conferences are held have Wi-Fi. Obviously not everybody has a smartphone. They run into issues around data charges for filling out things on your phone and uploading them that way. So we've gone totally old school and are doing paper pencil forms, scannable forms, I guess not old school, we're not hand entering, but scannable forms that are mailed to us at the Child Welfare Resource Center, which is our training and TA center housed in Mechanicsburg. And I was corrected by my colleagues, we actually have 4 levels of QA. So what happens is the facilitator completes his or her sheets. The family conference survey is distributed to everybody at the conference there. And then one of the participants sort of volunteers to collect those surveys and put them in an envelope and seal them in an envelope. So that way participants aren't handing their completed survey right to the facilitator. So hopefully they'll feel more comfortable being honest about their assessment of how the process went. And then the facilitator takes that sealed envelope and everything else and mails us a packet of information. And like I said, we have 4 levels of QA. So some of that happens before it gets scanned, some of it happens during scanning and after scanning. And quite honestly, this is the cleanest and best data we have because we have the most control over it. So then we wanted to talk a little bit about how to ease burden on counties. Again, this is a brand new piece. We're asking them to complete a lot of information. This is a lot of paper. And the two larger counties actually opted to use a stratified sample instead of collecting data for all of their families. So we worked with some colleagues in public health to develop a sampling strategy, and they're stratified for both of those counties by age and race and region of the county. That has had some pros and cons. Because workers in those counties aren't doing these forms consistently, it can be harder to kind of keep folks up to speed, and they're not as familiar with them. Turnover has a larger effect on getting those data in. And also we had to create those sampling strategies based on projected numbers instead of historical numbers. And so those counties are both much lower than expected in terms of where they thought those numbers would be. We've created a lot of different tools and aids. We created a user's guide that's very, very detailed that goes through sort of each item on each of the form, an FAQ sheet, and we held multiple webinar trainings where we walked through each of the forms, answered questions. We have a recorded version of that webinar that people can access whenever they want. And then relationships, the key to everything. We have an evaluation specialist. Her name is Alexis, and the family engagement sub-study is her project. And she has worked really hard to build relationships with folks in the counties, and has gone out to provide additional TA and training around these forms, additional supports, things like that. And also, as an evaluation team, we try really hard to be accessible. Folks will reach out to us, and we get back to folks within a business day at most, and again, have provided a lot of additional help and support. So that leads us to challenge number 3, which is how do we use this information as part of the CQI process? And this is really where we are right now. So we're just over 2 years into this project. And we have run into several challenges related to this. One is just time and resources. Obviously, we can't give feedback in real time. So if we're lucky, we get all the forms for June conferences by the end of July. And that's if we're lucky. And then it takes, a few more weeks to a month to clean all that data up and scan it and get it in. So it's not like facilitators can just click a button on a computer and get a report, quarterly report about all of their conferences up to then. And it's also been challenging to figure out how to get information to the right people at the right time. Again, I'm preaching to the choir here, but counties have a lot of competing priorities. They're involved in other initiatives, not just the demonstration project. Pennsylvania actually has a lot of new legislation around child abuse and neglect in terms of definitions and mandated reporting. And so counties have had to put a lot of time and resources into training their staff. And also we've experienced a lot of shifting organizational structures. 4 out of our 6 counties have had changes in administration or directors. So there have been big leadership shifts, including actually the second tiers of leadership. So there's been some shifts there as well. We had one county that had a brief labor strike. So just sort of, a lot of moving parts all the time, and it's hard to get people at the right time to talk to them about this so that they can then use this information to help inform practice. Where we are right now, we're working on, we're gearing up to submit our interim evaluation report, which is due to Bethany in February, I believe. So working on creating a fidelity index, so matching each of those survey items to one of the 5 core components. So then each conference will have sort of an overall fidelity score, as well as possibly sub-scores for the 5 core components. We're sort of playing with that empirically. So we want to be able to use that in analyses to see if and how fidelity relates to outcomes. We are developing a process for packaging data to give it back to them. Obviously, with their assessment data, the CANS and FAST, they have that in their computer systems, so they can access that data. But this they send to us. So cleaning that up and de-identifying data and getting that back to them so they can use that for their own work, and involving our practice improvement specialists, so folks that work for us at the resource center who are assigned regionally, involving them to help counties determine how to best utilize information to inform and improve practice. And I look forward to hearing of what Lynn and Tina have to say, maybe get some ideas from them. Just wanted to give a brief sort of thank you and shout out to our team, who I said is a really fantastic group of folks who are really committed to this work. And that's all I had. If you have questions, feel free, obviously, to ask at the end, but catch me in the hallway. My email address is map225@pitt.edu, so feel free to email me as well. Thanks.
Well, thank you, Dr. Perry. That was awesome. And it's really, I mean, you can see the struggle here of learning, figuring out how to gather the data, how to create less burden, how to begin to use that, how to create an index that makes some sense to people. All of those things are such important parts of what the program evaluation side brings to these waiver projects. My name is Ruth Hebner, and I have a long history. I've been around for a long time, so they're not going to read my bio. But I've been involved, right now, I'm involved as a 4E organizational consultant with the Center for States. So for some of you who don't know this, all the TA network that we used to have, the NRCs and the Quality Improvement Centers, most of those, their funding has expired, and they're rolling all of that capacity building services, and that's the new terminology, capacity building services, into a large collaborative that includes the Center for States. And the Center for States has consultants on the team that are specifically tied to the 4E waivers to help states implement these 4E waivers programs. So that's my current role, and I've got some experience to support that. But my job right now is to transition us to how we take the program evaluation data and information and translate that into program improvement using a CQI kind of process. And I'm told I should summarize the CQI process in 3 minutes, so here goes. A good, high-quality, high-functioning CQI process has a structure that has some leadership, not just at the agency level, but leadership at every rung down the ladder, right to the frontline practice and supervisors that are dedicated to leading efforts around getting better results. It has to have data, high-quality data, and we've talked about that. That's collected from quantitative and qualitative data. And as Dr. Perry just pointed out, somebody needs to make sense of that data. Somebody needs to pull that data, give it back to the people at the front line and say, now begin to use this data in program improvement and program enhancement. And that's important. All of us as evaluators, and I kind of come from that wing, need to figure out how to make the data make sense to those frontline people so that they can figure out what to do with it. If we just keep it up in our little ivory tower, it's useless. I mean, seriously useless. Then you have to have a method to share this. Regular meetings, regular systems, regular interactions, regular downloads, whatever, regular methods to share the data and use the data and information to make changes. You have to have, so structure, you have to have a process. Now there's multiple diagrams that depict the process of CQI. And I just chose this one because it was used by the Children's Bureau last year as the process for the academy, the CQI Academy that was taught across the states for those of you who might have been involved in that. But the continuous quality improvement always is sort of depicted as some kind of circular process. The key part of continuous is not that it goes on and on forever. and it does, and it's kind of depressing. But the other part of the continuous part of it is that you got to close the loop. You've got to make that whole circle. And the touchstone of that circle is outcomes. What are you trying to achieve? What is it that you're after? And how are you doing along the way? You know, what's going right? What's going wrong? Why is it going wrong? What can we do differently about that? Let's try those kinds of things out, but you have to go full circle and come back and say this question. Did what we did, whatever, did it make a difference? Did we actually get further along in achieving those results? Closing that loop to have that touchstone, always looking at what it is you're after, not losing sight. I call it keeping your eye on the prize. Always coming back to that. So the process has to be circular. And that question is what we did it make a difference? Did we achieve what we're after? Is the link to program evaluation. And this diagram comes from the Children's Bureau framework it's a long framework, to design, test, spread, and sustain effective practice in child welfare that was published in 2014. You notice the outer circle. The coming back, that kind of process that is coming back to the outcomes. It kind of ties CQI and program evaluation together. The data from program evaluation drives the CQI process, the improvement process. And finally, the last component, structure, process, and culture. This is the hardest one to achieve. This is the really tough one. To get a culture where people are really striving to improve, that they're not fighting about whether or not the data is correct and, you know, whether or not we're getting dinged and all that kind of stuff, but you're using the information to make enhancements. You're learning together as a team. That kind of culture is very hard to achieve. So structure, process, and culture, that's what we're after with the CQI process. So with that brief, and I don't think it was 3 minutes, I think it was probably 4, missed it. My CQI process will kick in. I would like to introduce our next 2 speakers, but let me just make a little caveat first. They used the CQI process whether they called it the CQI process or not. They used all of those kinds of things. And they're going to talk about the sobriety, treatment, and recovery teams. Now, this is the program that they're implementing for their waiver. But the data that they're presenting is from the implementation of this program within Kentucky since 2007. So most of the waiver projects don't have 5 years worth of good solid data to look at. So that's why we chose them to present today. They're a brand new 2014 waiver cohort, but yet they've been implementing this program since 2007. So we have a lot of information and data about implementation, fidelity, and how it's achieved. We're basing this is a study that is coming out, and it's in your references. But it's based on the work of Carroll. In 2007, published an article in Implementation Science, and he talked about 2 aspects of fidelity. 1, moderators of fidelity. All those things that support fidelity, the training, the contracts, the collaboration, all those things support fidelity, but they're not fidelity. Fidelity is really that bottom line adherence, as Dr. Perry mentioned, to the practices that constitute that particular program, to family group decision making and to START. That's the bottom line. Are the services delivered as they're stated? Okay? And the other part of that is, and this goes back to that touchstone, is if we implement with fidelity, it should improve results, right? I mean, we're doing this not to be great fidelity people, but to get the results we're after. So these 2 lovely ladies that I'm going to introduce here have been working with this program together. Now, they have and I didn't even bring their bios up here, but they have long bios, they have lots of experience, they're well placed. But what you need to know, and this is the beauty of this particular team, is that Lynn Posey, raise your hand over there, great, Lynn Posey, she's an assistant director of the behavioral health system in Kentucky, okay? For starters. But she brings that, she's from the behavioral health side of the house. And Tina Willauer, over here, is from the child welfare side of the house. And these 2 people together are in charge of implementing the START program that requires not just collaboration, but really integration of the two, the behavioral health system and the child welfare system together. So they're in charge of transforming that system of service delivery. So I think that's all I have to say. So without further ado, I will introduce Tina and Lynn to you.
Hi, everybody. Okay, can you hear us okay? See, we have to do everything together. We are a team. So we're going to stand at the podium together, too, because I imagine we'll interrupt each other as we talk, because we have so much to say. The one thing I want to say that Dr. Huebner, and I'm going to try to call you Dr. Huebner and not Dr. Ruth. I can call you Dr. Ruth? Okay. Around the state of Kentucky, we call her Dr. Ruth, and many of you may know her as that as well. She really made the difference for START. And I have to say to you that START began in Cleveland back in the 90s in the crack cocaine epidemic. But coming to Kentucky has grown it in a way that I never imagined, and that was because of what Dr. Ruth taught us about data. Now, old-time social worker here, 25 years, right? I didn't go to school, I didn't take math in school. I didn't like math. I was going to be a social worker, right? But when they threw data in front of me, quickly, early on in my career, I thought, well, what am I supposed to do with this, right? And so that's what we learned. So let me tell you a little bit about START, and it'll all come together. So START is for sobriety, treatment, and recovery teams. Am I going to push this off? I don't want to roll this off. It looks a little wiggly, doesn't it? Okay, sounds good. So START is really a child welfare program. That's the first thing that you need to know. And it's a program for families who enter the CPS system with co-occurring substance use and child maltreatment. It's the most important thing. We could talk all day about it, but I'm just going to give you some highlights so you kind of understand the program and what we're talking about. It was developed with the help of the Annie E. Casey Foundation in the 1990s during the crack cocaine epidemic in Cleveland. So I was just so lucky to be a part of that process as well. Was able to work it as a worker and a supervisor and really learn the model and learn the population. So that was a real blessing. We serve a very high-risk population. The original model served substance-exposed infants. And now in Kentucky, we've expanded that population to any family who enters the system with a child 0 to 5 who has a parental substance use problem. Our focus is on keeping the kids in the home, and you say, what? This is the highest risk population that we serve in Kentucky, but yet our goal is to keep them in the home safely, of course. They can't all stay in the home safely, but we believe that what the START model offers is a group of strategies, wraparound services, and supports that allow us to do that safely. We began in Kentucky in 2007, and we are also working in Indiana now. Indiana is rolling out their second site. We're working on that right now. So we're really hopeful that Indiana will kind of replicate and build on what we've already done. So a little bit about START. The model looks like this. We pair specially trained workers, CPS workers, with family mentors. And together, what they do is share a caseload of 15 of the highest risk families. So we have 15 families. Now, our family mentors are very special, and I guess you could consider that one of the best strategies, one of the best things about the program, because family mentors are persons in long-term recovery who've actually been through the child welfare system. So many of them have had a substance-exposed infant in foster care and were reunified. These are individuals who now have at least 3 years of sobriety, are involved in active recovery supports, actively involved in their community, and we consider them part of our team. They're paid employees. We don't make a decision without them. They are part of what we do, because what we do is shared decision-making with families, with everybody at the table. And so that's just a little bit about START. The other thing to know is that we have a very rapid timeline for the first 30 days of a START case, and that's really what kind of makes us different than typical child protective services, is that we get engaged very quickly. And we'll talk a little bit about that, but that's where our fidelity comes in, because we're getting people involved right after that report. We're not waiting around for 30, 45 days till the investigation is done. We want to be in there within the first 10 days, because we want you in treatment in the next 2 days. I mean, it's just that quick. So that's a little bit about START. And I guess this slide is kind of, I'm not going to read it to you, but I guess when I think about this slide, I say this. Folks, it's more than a notion to try and put this all together. Not only the pre-work that you have to do to get ready. I mean, the touchy-feely values discussions, those are important. We find those to be some of our biggest barriers if we don't do a lot of work around those issues. And you enter the honeymoon and everybody's excited. We've been working together for years with behavioral health. We're great partners. we're throwing down 4 months later, right? We're throwing down at the table because we have to really talk about those issues that we really don't agree with, right? That we really haven't examined. So it's really kind of pre-work, but then it's ongoing work, right? Because if you don't continue to nurture it and build those relationships, which is what Marlo said, it's all about relationships, right? And so really changing the culture takes years. And what Dr. Ruth told us, and I told new sites this and they roll their eyes, and I rolled my eyes too, actually, when she first said it, and that was, to full fidelity, implementation science tells us 2 to 4 years. And people usually say, well, we want to get it going next month. Well, come on, we have to spend this money by July. Well, that is not how this works, folks. We have learned this in the last 8 years in Kentucky. So just a little bit about START participants, lots of words on this slide, but basically thinking about this population we're working with, we work with moms and dads, and we work with high-risk children. So when you look at it, about 67.7% of our families had a newborn child, 30 days or less. So again, a lot of really young children. This study went from October of 2007 to February of 2013 with 341 families and 550 parents. On average, our cases last long, 16 and a half months, that's on average. And almost all of the parents have substance use disorders. Every now and then you have a non-offending parent who may not have a substance use disorder, but most of them do. We're talking about young families here, folks, and I know that you know that. The average age of our dads was 29, and our moms around 26, 27, and most of them are polysubstance users. Gone are the days of the garden variety alcoholic in the dirty houses, right? That doesn't exist anymore. We have folks using opiates and benzos and marijuana. You know what I'm talking about, right? Now, our kids are very young, too. If you see our kids, are 1.3 years was the median age. About half of them were a year or younger. Now, we serve the whole family, but at least one of those kids has to be in that age group, which makes it very, very high risk. So we'll leave it at that. All right, so here's our START timeline. This represents the first 30 days of a START case, and it's a visual tool that we use with our staff. And it outlines the fidelity measures for not only CPS, but also for behavioral health. Now, I have to tell you that when I came to the state of Kentucky back in 2007, negotiating this, wow. Dr. Ruth, I think you were in some of those meetings. It took forever to negotiate the idea, like that first box, we would like our investigative team to refer the case to START before the investigation's even over. In fact, we want that case as soon as you know. If it's 3 days in that you know that family needs services, call us, and we're gonna get rolling on services. Now, that first yellow box, just so you know, 24 hours, it used to say 30 days, because when I came to Kentucky, they said, no way, we can't do that, and we're not gonna do that. Okay, fine. Well, you see now, after 3.5 years, we saw that we could do it. So we shortened it and tightened it to what we had in Cleveland, right? And that was 24 hours to 10 days. And you can kind of walk through it. I carry this with me, and I pull it out at every meeting. What about this? And our staff have it hanging up, because it really does represent to them what fidelity means. You tell a frontline worker, well, we need fidelity. It doesn't mean a lot until you visualize it, you work through it, and you actually share with them what it is that we get out of it and how it makes things better for families. So I think that's what I would say about the START timeline, and I think Lynn's going to take over and give us a little more detail.
All right, so the START timeline incorporates both the CPS part of what we need to happen really fast, from the report to being referred to the START team to that very first family team meeting, but it also incorporates the behavioral health part of the timeline, that we need an assessment within 48 hours of that first FTM, and usually it happens that day of that first FTM. And then we need to know what the treatment recommendations are within a day, and then they need to be in treatment within 2 days. And then the measure that we came up with to determine if they're like really getting started in treatment, not just they got their first appointment and a month later they get their second appointment, was would they get 4 treatment sessions within the first 2 weeks. So this chart is our timeline in a chart format, so it's kind of in the data chunks. And the data that informs this comes from 3 different places primarily. Our SACWIS system. We have a data system that the workers and the mentors put information into, so we pull dates out of that, and then our providers also input data. And when we initially did the evaluation, the timeline, because we gave them 30 days, you know, to refer to start. So initially, our goal was within 45 days. They've gotten through all these different steps, and they're you know, good and well in the START system by then. So this shows you after 1 year of ramp up, obviously that's very early in implementation, right? We were doing okay. For instance, the START referral, well, this helped us to realize that maybe we didn't really need 30 days, because 30 days was our goal, but our average was 13.7 days with the red bar. So we're like, we think maybe we can shorten that. You know, maybe we should make our goal the 10 days. And so we did. Then the blue bar, our goal was 3 days, and you can see we were a little over that, 4.5 days. The green bar, our average was 13 days, but our goal was 2 days, so you could see we had some work to do there after a year. And this is this green over is our behavioral health part, and we really had some issues, and I can own that because I'm the behavioral health part of this team. We had some issues, really getting people in quickly for their assessments and into treatment. So the purple bar, our goal was 3 days. Getting to that first treatment in 12 days was our average in year one. And then completing the 4 more sessions, the yellow bar, our average was 73 days. That's a really long time, and it was supposed to be 2 weeks, right? 10 business days. So that's a crazy long amount of time. And what that means is that, we weren't doing so hot. After year one, we had a whole lot of work to do, right? And what did that work look like? So now that we had some data to reflect on, and we, would get that feedback loop pretty frequently, it empowered us to be able to work with the team to help them figure out how can we make a difference in this. So here's some of the different strategies that we've used over time that have worked pretty well for us, and there's tons of them. And the fact is that you try a strategy, and then you try the next strategy, and then you try the next one. You keep cycling through, because sometimes it takes lots of different efforts. I see heads nodding. So these are some of the different things that we did, and we meet regularly. So, just to say that, with our teams, once a month, direct line, talking things over, presenting data to them, looking at how are we doing and how can we do better with all these things. So I just want to tell you a little story that fits with, how we get to fidelity. And this story isn't yet resolved because it just came up in the last week, that we found out that out of the last couple of months, 5 people had gone to detox and had only stayed for 1 day in a detox program. And detox usually takes 3 to 10 days, depending on what you're detoxing from. And so if you're leaving after 1 day, that's a problem. Yeah, because you're not done withdrawing after 1 day. So we're like, what's the issue here? And what we came to is that at this site, everyone's addicted to heroin. So, and this particular detox unit, they like to do social detox. And we had worked with them a long time ago, put it in their contract that it was okay for them to get their doctor to prescribe medication. We talked about how that's an evidence-based practice, to use medication during withdrawal and or to just put people on medication-assisted treatment altogether, that's an evidence-based approach to working with these folks. So those are some of the things that we've done in the past. It's time to revisit that question again, because our data is showing us that we're still not, people still aren't getting their 4 sessions within the first 2 weeks. So we'll be talking with the providers. So ask us a month from now, we'll tell you how we're doing with this. But our plan is to sit down at our direct line, talk with our providers. We'll be problem solving. We'll be reviewing, why is medication during withdrawal evidence-based? How could it make a difference to our detox? And then if we need to, the last one, call in the big guns. You don't really want to pull that trump card very often, but sometimes you have to, right? Sometimes you have to, pull that contract back out and say, it says right here. And sometimes you have to go straight to the CEO. I mean, we talk about, lunch as our secret weapon. That we'll sit down with the CEO of the detox agency and just talk about, here's the issue that we're having. Can you help us work through this with your staff? And some pretty amazing things can happen. Now, Tina's got an example from the child welfare side of the fidelity strategies.
So all these strategies are really important, and I think a couple things to say, that the data is so necessary, but it's not sufficient, right? There's so much more to it. You have to make it meaningful to people, like Dr. Ruth said, and it never used to mean a lot to me in the past. I come from other organizations and projects where we might get beat up with the data because it didn't say what our administrators wanted us to say. So it didn't really empower me to use the data to improve my practice at all, right? So anyway, on this other side, if you kind of look at some of the other things, the other strategies, case reviews and consultations, sometimes it's a matter of we think we're there, maybe we're not. The data says that. Let's get in there and talk to the staff. Let me sit through your case consults. So, you know, as a director and assistant director, we go to many of our case staffings each month or sit in consultations and listen to the staff talk, and we can identify sometimes, oh, wait a minute, something that's a gap. So it could be that simple. And in the process, we're also growing our supervisors to understand and learn how to use data with their staff as well. So it's a real circular process. One of the things that just recently happened too, and I'm trying to see where does it go, work with intake teams. So the folks that investigate the reports for child welfare. So what we found recently from our data, which was really fascinating, we have 4 sites in Kentucky right now. One of them's a federal grant site. And at our federal grant site, what we recognized is our intake team was not getting cases to us quickly. In fact, when you compared them to the 3 other sites, we're talking like 2 weeks later. And remember, we've got 10 days for the intake team to give the case to START, or at least to involve START. So what we did, or what I was able to really have a good conversation with the head of the child welfare organization in that region. And I said to him, and we kind of sat down and looked at the data and showed him. I said, well, look at here. You've got all 4 sites. You know, our whole idea is to get quick access, right? So we can't do that if your intake folks aren't getting us the information. So what's the barrier? One of the suggestions we came up with is some of our teams like to add an investigative worker to the START team because it tightens that timeline a little bit. He was a little resistant to that. He said, I don't like moving staff around. I don't have a lot of staff. I don't have a lot of staff to give. I'm not sure about that. But then when we sat down and looked at the data, he was very bothered that his site, the grant site, was 2 weeks behind everybody else in the state. And he said, well, don't you know that a week later, he met with that supervisor, and there's an intake worker on that team right now, and I'm certain that we are tightening those numbers. I mean, anecdotally, right? So we'll look at the data again pretty soon, but that was such a good way to teach him and to help him understand that, and he's been in child welfare as long as I have, so he understood the implications. So it was really important, and I just wanted to say to you that I think that, you know, talking with the staff and listening to the staff and really helping them understand and connect the dots makes all the difference. So that was kind of, in a way, calling in a big gun, right? I mean, we had worked at the direct line table, and he was the top of the food chain in that particular region. So really, really helpful. The other thing I want to say is you rarely get to fidelity without cohesive teams. End of discussion. You just don't. And so Lynn and I work really, really hard on both sides of the fence here on really making sure we work together. I love to hear behavioral health people talk about child safety. And I love child safety, or child welfare people talking about behavioral health, that they have an understanding. Why? Because of all these things that we do. So I don't know if you want to say anything else about that, or? No? We good?
Yeah, I think we're good. So the question is, after year 1, how did all these strategies pay off, right? So I think you can probably see this from over here. So the top bar, the gray one, is how long it took us to get to those 4 sessions. Remember, that's where we were really in trouble. And you can see we went from 73 on average in year 1 all the way down to 23 on average in year 4. So we're still not quite meeting our goal in year 4, but we're so much closer than we were. So we're happier. And then the blue bar is the how long it took to get from the report to CPS to the to intake. And you can see we went up a little bit in year 2, but then we went down, so we're at 11 after year 4. So that's pretty good too. And then our orange bar also decreased, and that's how long it took to get to intake. So we made lots and lots of improvements, which added to, as a sum total, if you add all of those data points together, we had 122 days the first year in our And then all the way down in year 4, 46 days. And our goal was 45 days. So pretty good, right? So it took a lot of work to get there. That's what I want to say. You'll also notice that in year 3, we were down to 39.8 days. And then in year 4, it went back up again. Wonder what's going on there. You know, the thing is, you can't ever rest. You know, you're like, we got there, but then you have to keep at it, right? You have to keep revisiting your data. You have to keep revisiting your strategies. And of course, I mean, somebody else mentioned staff turnover. That's huge. Every time you have new staff, right, you have to go through it all again, and you're building the team again, and all that sort of thing. So just to say, empowerment evaluation never ends, which we're glad about that. Yeah. This is lovely too. And this is kind of the take-home story of how fidelity is tied to outcomes and and practice. And this is our payoff, and we also call it our elevator speech. So you'll notice the red bar, as we got better and better at shortening our timeline, at being, at fidelity with our timeline, we also saw improvements in the green bar and the purple bar going up. And that's how many moms were achieving sobriety by the close of their case, and how many of the children were able to remain in parental custody throughout the life of their case. That's the gold, right? The better we get at doing our program with fidelity, the better our outcomes are going to be. I love this slide. Thank you, Dr. Bruce. So here's some references that might be of interest to you, the whole implementation science article, and then the 4 articles that are either already published about START or are in press currently with START. I also want to give a shout out to our current evaluator, Martin Hall. Raise your hand, Martin. Thank you. He's the lead author on the one here about working in Appalachia. So, and then here's our contact information. We would love to hear from you guys if you got ideas or questions or whatever. So anything else you want to say?
No, just thank you.
Okay, and I think we're ready for questions now, right? Yeah, thank you.
We're going to get the microphone down here because we're recording this.
Yeah.
Bring the mic
If anybody,
down.
if you have a question, you can please raise your hand so we can bring a microphone over.
How many families are you able to serve at a time in one of the sites?
Hi, Doris. I remember you from Indiana. So at one site, so it just depends on, and again, depends on how your state counts families and cases, because in Kentucky, we count by cases. In Indiana, you count by kids. And so it's really different. So we, any worker mentor dyad in Kentucky will serve 15 families at a time. That's too high, just gonna tell you. The original model was 12. But no child welfare system that I've ever worked and tried to build START in has been able to sustain it because everybody else is dying on the vine with heavy caseloads. So really it is 12 to 15 families, 12 is optimal. In Indiana, I love what you guys are doing because the caseloads are smaller in START. Well, in theory, right? And basically that's what you guys are trying to do, and it should work great because you're counting by kids. I mean, if you think about it, 4 families, you could have just about the capacity of kids of that for Indiana, right? So that's how we do it. Each dyad is 15.
Right. And then we have 3 to 4 dyads per team. I mean, we have one site that had 2 dyads, and because this is such a team approach, I mean, we're just really working together, and you have a supervisor, and they're supervising the workers and the mentors together, and so they need to have enough people to count as a supervisor without having to get pulled in other directions. So 3 or 4 dyads is a really good size for one supervisor. So in our 4E site, we'll have 2 teams of 4 dyads each.
You have
So
something
that's
else?
120 families.
I think she has a follow-up
Math
too.
person.
This may be for Dr. Perry, but for any of you. Do you know of an instrument that rates the quality of the case plan? Or did you develop an instrument that looks at that?
Let's see. You can call me Marlo, first of all. I can't even get my students to call me Dr. Perry, so I'm not used to colleagues calling me Dr. Perry. No, We are using the SPANS, which looks at how CANS information is incorporated into the service plan. That's not really getting at the family engagement piece of things, but we are utilizing the SPANS for that, and I forget what that acronym stands for. Service Process Adherence to Needs and Strengths, I think, something along those lines.
And just a little suggestion too. In Kentucky, we use the regular case reviews. There's case reviews being done regularly for all kinds of things, and they're all put into a database, and they're done by supervisors and specialists throughout the state, and not unique to START. They're done for all cases. So we were able to pull that data and identify the START cases and compare those to the cases that were similar in terms of need, and found that there was indeed higher quality of casework. Now, we also found some problems too that we worked on. But so don't ignore the capacity of your, and all the work that's being done with your state to do case reviews and to be able to kind of pull that rather than creating a separate system, which is very labor intensive.
As you're rolling out the initiative, before you had that really exceptional chart that you were so proud of at the end, what would you say to newer states or states that are in that second year who are rolling out performance measures? I'm using a scorecard in Wisconsin with 36 counties, and it's good, but it's not great yet, and we can't exactly say we've got the findings. So what would you say about building buy-in while you're simultaneously pushing performance management, helping the providers and the case managers and the supervisors understand that this is the program that we're trying to implement and monitor to fidelity, but we don't know it works yet. How did you bridge that conversation?
I don't even know what I'm going to say here. I have no idea what's going to come out of my mouth. So I was looking at Lynn, like hoping she would take this. I think here the first thing is building those relationships, because you're right. I mean, when I came to Kentucky was, I don't know about this. This is pretty risky. So I think it goes to culture change. And in year one, you're going to have naysayers. What we found was there was a honeymoon. Everyone's so excited to be a part of a great project. And then when it gets down to the brass tacks, people start questioning it, like, oh, I don't know about this. They start questioning us, who are trying to push them, right? They start questioning the evaluator. And I think I'm going to say, you continue to meet, you continue to have those discussions, you continue to motivate, you are a champion. I mean, there are days when I know I'm not feeling it, and I go in that room and I am the champion because that's what they need to see and that's what they need to hear, and it's constant, continuous pushing and changing and showing them how much better it is for families. Here's the other thing for us, is we have recovering people on our team that are peer support specialists, and they tell us every day. They tell us every day, oh my gosh, if only I had this, if only that, and it made all the difference. Now, if you don't have that, there are other ways, and Lynn, do you want to talk on this?
Well, I was going to say, I think an important piece until you get to the point where you can start measuring outcomes is to keep giving the team feedback about how they're doing on the fidelity measures and to celebrate them. Because of course when there's issues with them, it's like, okay, we'll problem solve this, but to celebrate like every single, positive part of it. Oh, we're getting so much better, or we're so much better than we were in year one, that sort of thing. So I think that can really help keep the energy up. And also, I really feel like Dr. Ruth did such a nice job of involving the team in thinking through. I remember one meeting in particular, we kind of thought through, what was our model? Like, what in our model? Our change model, our theoretical, what am I trying to say? Well, how we, yeah.
The theory of change logic model.
How did we think what we were doing was going to tie to outcomes? And I think that was a really powerful moment for the team to be a part of that process of putting together what they're doing with what the outcomes that we were hoping to see were. And then when it came time to give the outcomes to the team, they were already thinking along those lines. So, yeah.
One more thing. Dr. Ruth said it early on, building leaders at all levels. And that is at the very top. And it took a long, I think you got the ground people on board way before leadership was completely bought in. It took a little longer. But to have champions on the ground, your family mentor, your worker, your supervisor, your intake folks. Our intake supervisors became some of our biggest cheerleaders. Why? Because they realized getting a case to us faster helped them. Well, good. It helps families too. So again, if you can find local champions, I know on each team I've got at least one person that I might have to pull aside and go, look, I need you to speak up a little bit more, just stuff like that even. So.
One other thought I had is that, our ultimate outcomes, better sobriety rates, more kids staying in the home, those are really important, and those are the big sells, right, for the legislature and the governor and that kind of thing. But the little things along the way were sells for our programs, for our systems, just getting people in quicker into behavioral health services had been a huge barrier for years. And so people were excited just about getting better on that in itself.
All right, one more thing, guys. Celebrating successes. This may seem really cheesy, but we've decided that every single meeting that we begin with is bright spots. And everybody has to go around. And usually a bright spot for a worker is, I got somebody in detox and they stayed and now they're in day 30 of treatment. And we are all excited about that. So just every little thing matters.
This is a question from Massachusetts.
Oh, over here.
Sorry.
That's okay.
About many's the slip twixt the cup and the lip. Are you able to report on the percent of teams that complete all of their fidelity forms on time and get the data to you? The reason I'm asking is I think it's not a stretch to figure that the ones that report are the ones that are most likely to adhere to your principles of practice, and the ones that don't report, their data is missing, and they're the ones that may perhaps are the least likely to adhere to principles of practice. So how do you account for that?
That's a good question. I'm not sure I have a great answer for that. There are definitely, we essentially have to kind of trust what the counties are telling us in terms of the groups that they're having. It's easier in counties where they have these contracted providers that are doing things, and maybe it's a cleaner intervention with one model. So then when they're reporting numbers for like the program monitoring piece, we can compare those to numbers of data that we've gotten in and see how comparable those are. We do report back numbers that we have gotten to make sure that those make sense to folks. And we've definitely been in close contact with the two counties that are doing the sampling strategies to talk with them and brainstorm about why they're so far behind where they thought they would be. But we don't necessarily monitor, percentages on a monthly basis or anything. Like, it's more informal, and it sort of just depends on the needs of the county and where they are in terms of implementation and how things have gone.
Thank you. I was just wondering if you could talk about the supply-demand issue in terms of the need for treatment beds, and if you had wait lists as your workers were trying to make referrals, and how you managed it or how that impacted it.
I'm sorry, I didn't really catch your question. Can you?
I was trying to figure out in terms of the referral process. So in Massachusetts, we often have a wait list on our substance abuse beds. And so if folks are obviously looking to refer a parent and there isn't a bed available, kind of did you guys have that experience? And if you did, what did you do? Or was there anything you could do?
Yeah, so we have had to implement multiple strategies around that. One thing I can say is that probably 70 to 80% of our parents go through an intensive outpatient program, and a lot of times they don't have wait lists like residential and detox facilities do. Now, I will say that some people just aren't going to be successful in an IOP unless they've gone through detox or residential first, so just to say that. So we've had to develop contracts and agreements with providers. Sometimes they'll save a bed out for us. Sometimes because we have a funding source, they're more likely to have a bed for us. So lots of strategies like that. We also work with a lot of different providers. Now that we have an open provider network with expanded Medicaid, we'll call every one of them until, we find if there's a bed. And sometimes we'll have somebody attend outpatient or an IOP until they can get into residential, that sort of thing. So they've got lots of contact and supports until they get to the level of care they need. And sometimes, surprisingly, they end up not needing residential because they did okay in IOPs. So, yeah, so it really varies. Oh, here's a link, I guess.
Okay. So this question is for Marlo. It was about, you talked about all these different types of family meetings and family conferencing that was going on that you were evaluating, and then you talked about what they all had in common so that you could evaluate it, which I think is really great that you were able to pull that out. And I'm still stuck on what about the differences. So thinking about sort of waiver demonstration, the whole process, that what we're hoping is that what we can find from all the different states is this works really well, right? And so if you have, your results will show family engagement is really great, right? I mean, more than that. I'm simplifying your argument. But have you looked at the differences and evaluated which of these family engagement, family teaming, family conferencing models is really the best one that we should be replicating throughout the nation?
That is a good question. We have not done that yet. Again, we're gearing up for our interim evaluation report. It's challenging in that we're tasked, obviously, with doing a statewide evaluation. So we're not really in a position, resource-wise or task-wise, to do 6 different county evaluations. But I think we definitely will look at some of those major differences in terms of maybe that private family time piece. Trying to think. I think too, sort of on a larger contextual level, we'll be able to piece out if there are differences where those may be coming from. So it might not necessarily be specific to a model, but more, a county that had a system already in place and they just expanded their volume versus a county that did a major overhaul in terms of now caseworkers are facilitating these meetings, and that never happened before. So especially this early on in the project, I wouldn't necessarily assume that if that latter model isn't successful, that it's specific to the model itself. It's probably just more in terms of this is a brand new initiative that folks are trying to get off the ground, and there's a lot more involved in training than I think counties anticipated. So I think we'll get at some of that. I'm not sure how fine-tuned we will be able to get, but that's a good point.
Marlo, this is another question for you. When you look at the data from your surveys of participants in the family engagement meetings, do the results seem to be pretty similar regardless of which kind of participant is providing it? Like if you have a meeting, do the families tend to rate things sort of the same way that the facilitator does and that the workers do, or do you see a lot of variation in there?
Yeah, I mean, for the most part, these are skewed in the way that, even though we're trying to gear it more toward assessing fidelity and not satisfaction, they're still sort of skewed in the way that you would expect surveys to be. So very generally rated pretty positively. For the most part, professionals and family members do rate things pretty similarly, with the exception of, I believe, one item that asks about I don't remember how it's worded exactly, but did the facilitator tell the family what to do? And professionals and families tend to rate that fairly differently. So we have done some factor analysis with the earlier FGDM version of that, and so there are slightly different factor structures for professionals versus family members, but there are more similarities there than differences.
So this is kind of building on the earlier discussion around the idea of fidelity measurement or practice measurements and outcomes measurements. I think at this point, for us, we're experiencing some pressure, particularly from leadership partners in the program who are really focused on outcomes, or we're ready to see, is this working? And I guess the specific question is, how soon can you start saying outcomes and having some faith in that? You know, we kind of keep redirecting over to, well, look at the fidelity, look at the the practice, but how soon, what number can you start looking at in terms of outcomes?
We're deferring to you, Ruth, on that.
When you're first with the waivers, you have a lot more resources for evaluation. I was one person and with a huge lots of responsibilities. So, having said that, but also commissioners and directors and all those things, they need to know that kind of stuff. They need to have some kind of handle. I know we had a change of leadership right after the START program came to the state. A new, the Democrats took over from the Republicans. It was messy. And, the commissioner said, I want to get rid of that START program. I said, give us a year. We just got it going. Give us a year. And if we're not producing any of the results that we think you should see, then we'll get rid of it. I'm fine with that, So you have to figure out some way of looking at what those critical issues are. What are they really looking for? And figuring out a way to measure it. And we were able to do that. We had some measurements that were saying that as we were moving through, we were getting double the rates of sobriety and half the rates of out-of-home care placement. And after 1 year, we sort of said, we're not up to fidelity and we're not even close, but we're seeing trends, and this is the difference in it. She didn't care if it was statistically significant or anything like that. She just wanted to know if it was clinically significant, and for her, that was enough. And she was willing to let it continue. So those are important issues, and I know that we oftentimes say, well, you never can measure outcomes until you get fidelity going, and you shouldn't try to measure outcomes too early because you might be wrong, and you might. All those are things, but the reality of the political situation is you better be able to figure out some way of at least talking about any benefits and downfalls of a program, even if it's focus group data or interview data, something, because these programs are vulnerable. Go ahead, Marlo.
I don't know that I have anything to add.
So I have a two-part question, and I know that Kentucky, like Indiana and many other states, are experiencing higher rates of substance abuse and more kids kids and families involved with their respective systems. So as we think about implementation of high-fidelity evidence-based practices, just thinking about how you maintain fidelity to the model with increased pressures on your system is the first part of my question. And then the second part of my question is in thinking about the realities that you're having to work with more families with substance abuse, for instance, trying to be able to scale up to meet the needs of those additional families on a larger scale, and so that you can have those positive impacts on a larger scale as opposed to just being able to impact smaller populations.
Really good questions. I think I could maybe start with the scale-up question. That we started with a couple of sites and then a federal grant site that was a very, very small community, learned a lot from that. Part of what we learned was kind of an economy of scale, so that when it came to the 4E waiver, we knew that we needed to go where we could make the biggest impact in foster care usage, right? So that we could afford to have a waiver. So we had to select communities that had a large enough population to fill up our team so that we could really impact foster care numbers. And we had to look too at, different communities have different rates of foster care usage too. I'm sure you find that in Indiana as well. And so that had to factor in. There were some communities that were, really wanting to implement the program but had pretty low foster care numbers. We're like, not really sure that we, could have a big enough impact in those communities to be worth the $40 there. So I think with a program like START, which is pretty time, energy, and staff intensive, the idea that we could have a START team in every county is probably not realistic. But we could have START teams in the larger communities that then are kind of hubs of influence for their whole region. Even if you couldn't have a whole START team everywhere in the state, you could at least use certain strategies. For instance, moving people from investigation to an ongoing team quicker. Identifying, because there's substance abuse, that this person, that we're going to substantiate, okay, how can we start getting services in quicker instead of letting it, just kind of linger for 45 days and then, the family, there's like no urgency at all at that point. So just different ideas like that.
Doris, remind me the first part of your question again, because I'm thinking about this now.
About maintaining the carve-out for the staff who are dedicated to that, it's very labor-intensive practice.
So you're talking about, are you talking about drift and making sure they stay with Fidelity throughout?
Yeah. As caseloads rise, because when there's a carve-out, that means that the additional cases then get distributed elsewhere.
That's right.
So,
that's right.
Organizationally, that's challenging.
It is true. Oh my gosh. Wow, I was shouting, but look I don't mean to yell at you, Doris. You're right in front of me, but so really, I think that is one of our greatest challenges right now. We have, and I think it absolutely, with Fidelity, it hurts it. I mean, so many different things. I think turnover is one of the biggest things. First of all, turnover, because you got to have a backup plan for what you can do with all those cases when someone leaves, and we found that in one of your sites, and we find it in all of our Kentucky sites. So I think planning in advance for that. So now when we go into sites, we say, okay, what's the backup plan? And are we committed to having this innovative program and having it change the culture of the entire office, but still having some equity in caseloads, right? And so that's a discussion that must include leadership. And I will tell you that right now we're having those discussions with our 4E waiver. We're trying to staff the new 4E waiver team. And, nobody wants to give up the good workers from the rest of the agency because we don't want to rob all the good workers, right? So it really is an ongoing discussion with leadership, with some of the staff, like the supervisors, and really talking about, is it worth it? What's the payoff? Now, I will say to you that our intake teams love it, right? Well, that's fine because we carry the ball. So the quicker you get us the case, we carry the ball. It's the ongoing teams that have the problem. However, they kind of like the idea that we take the highest risk cases, and when we become, again, part of the fabric of the agency, we become a resource for them as opposed to this little team that gets lower cases. Because, by the way, when we open up and say who wants to come to START, not that many people want to come. You really want 15 families that are all in active addiction with babies? Really? Does that sound fun? It's not fun for a lot of people, right? And so just talking about all those different issues and convincing leadership, that there is a balance. There is a balance. And where's your priority? I don't know. Dr. Ruth, do you have anything on this? No?
I was just going to add that as the pressure has increased, like as heroin has swept the state, it's actually I think influenced the decision to spread the model, actually. Like in Louisville, our biggest site, for every one family we were able to accept in the program, we had to turn 2 away. So between the outcomes and now, our 4E, we're able to expand the program. And I think that pressure helps the leadership make decisions about expansion and where to expand and that sort of thing.
Well,
so I think it's helped, in some ways it's helped to maintain it.
And staff buy-in too. You get people hear about it and say, we want this, or the people actually in Louisville now realize, oh, it's improved our practice overall. And we have some data that says that it actually has improved practice across the site. And so after 8 years there, they don't want that taken away. They're excited about this building, and so you don't hear as much complaining about it. It's part of the culture now. I don't know if we answered that, but as best we can.
Hi. Do you build time into your process to give feedback to state administrators, particularly focusing on things that may not be working as intended, have Fidelity the model, maybe they're reaching the wrong target population, or they're not giving the service with the right intensity? And do they ever actually make changes during the course of this whole process, rather than waiting to the end?
We definitely do make time to meet with our state leadership, our regional leadership. We have a meeting with our central office staff periodically to review how we're doing in all the different sites. They're very active in the decision-making process about, where to go and where to allocate resources and that sort of thing. And we tell them the good, the bad, and the ugly, because we know that, the ugly can come back on them too. We want them to know what's going on and what we're doing about it. I'm not sure that we found that we're not meeting our target population, because we're working with people who have reports to child welfare for substance abuse.
One
so-
possible example, that might be your example, but do people actually make changes during the course of it as a result?
I'm trying to think, have there been any major changes?
Are you talking policy changes and things like that? Because that's really what
It
we're
could be
trying to get at.
practiced.
Oh.
Let's say one of your providers isn't implementing it with fidelity.
Oh, yeah. We've had to change, contracts over time, and, there have been a couple of sites, frankly, there were 2 sites that started up one for a political reason, and it just turned out that it wasn't a reasonable site, and so when the administration changed, that site closed. So, so maybe that would be an example of how, sometimes decisions are made over time. And we had to go back to the second administration and say, well, this is why that site was selected, and here's the issues that we're having there. And there just wasn't enough population there to support a team, basically. So, so then that one was shut down.
All right, we're at time now, and I want to be respectful of the fact that we only have an hour for lunch, so I want to let everyone go. But I want to thank our presenters again today for doing a fantastic job. And to please let us know if you guys have any more questions, if you have any follow-up question or ideas regarding technical assistance for either evaluation from James Bell Associates or for a programmatic TA from the Center for the States, and talking to Dr. Ruth. Thank you.
Dr. Ruth Tolliver, right?
She came out.